It's all ready to go.
Good morning, everyone. I think we'll start. It's precise. Peter, quiet. I love to do that. Good morning, everyone. My name is Bev Adams. I'm the Vice Dean at the Cummings School of Medicine, and we're hijacking your rounds today for a very important presentation by Dr. Vikas Kuriachan, who I think needs no introduction. He's been doing a fabulous job as your interim department head. He's also applying to be the academic and clinical head permanently. Well, not permanently, but at least for the next 5 years going forward. Maybe we can talk him into more. I'm not going to do a land acknowledgement because Dr. Kuriachan will do that. And I'm actually not going to introduce him a lot because he's going to tell us a bit about himself before he launches into the vision for the department. I'd ask that you all provide feedback. I think you all receive feedback forms electronically. So your feedback is very important. And think of some questions, nothing hard, but something that's going to be supportive and useful for the department. So without further delay, I'll introduce Dr. Kuriachan.
Thank you, Dr. Adams, and thanks everyone for coming in person as well as zooming in this morning. I will just start with the territorial acknowledgement and go from there. So just to recognize that we should acknowledge and pay tribute to the traditional territories of the people of Treaty 7 in southern Alberta, which include the Blackfoot Confederacy, Tsuut'ina Nation, Stoney Nakoda, as well as the city of Calgary is also home to the Métis Nation of Alberta Region 3. These are my disclosures. The industry ones are for either research or honoraria. They're usually companies that are affiliated with electrophysiology or with DOACs or heart failure medications. I've also put on the disclosure that being the interim zone clinical department probably gives me some insights and things probably that are helpful as well. And I did kind of make the slides more oriented for a Zoom presentation. There's a few slides where some of the things are going to be a little bit small. I wasn't sure how many people would show up in person, but barely a lot did. Most of these talks are usually a little bit about your own background. So part of it will be that, and then part of it will be kind of looking at our departments for challenges and opportunities. I do have a few slides in the very beginning just on the organization and our leadership structure, because a lot of people have asked me questions about this just because there have been quite a few changes in the last year. As you know, we sort of work with 3 organizations for the most part, with Alberta Health Services, the Libin Cardiovascular Institute, as well as University of Calgary Cummings School of Medicine. And we kind of think it as a partnership between the 3. Until last July, there was one department head who was kind of the leader for all 3 aspects that was relevant to us. And this got split up in last July, where I was the interim clinical department head. So that's the AHS side. And then Dr. Fedak remained the Libin and University of Calgary academic head. Starting in July 2023, the academic and clinical department head position will be one, and that's the process undergoing right now. And then Paul will continue as the director for Libin Cardiovascular Institute. And this structure is actually pretty similar to a lot of the other institutes are set up. So this is probably more in keeping with what happens in a lot of other places. So in terms of how the leadership governance structure is set up, so the department head reports to both the AHS side as well as the university side. So that's Dr. Peter Jameson and Dr. Beverly Adams. And much like in our system, there's usually operations side partner, that's Amanda Wise, and then a department manager for the medical affairs side, that's Andrew Jenkins. Of course, there'll be sort of section chiefs and site leaderships. We have 4 sections in the department, and cardiology and cardiac surgery are the 2 sort of principal ones. We co-share cardiac critical care and cardiac anesthesia with their own department. And then starting in July, Paul will be the Libin director, and Libin has its own sort of governance structure that closely works with department side for Calgary, University of Calgary, as well as HS. So the rest will be a bit on my background, and these are always awkward to give because you have to sort of brag about yourself a little bit, but I'll sort of go through it. So I sort of just read it chronologically. I thought that was probably the best way to do it. So I was born in southern India in a little town called Palakkad, which is about, by Indian standards, is small. It's about 500,000 people. spoke Malayalam, so that's the language that's written on there. It says Palakkad in Malayalam. And I lived there till I was 9. My dad, when I was about 4 or 5, actually moved to Saudi Arabia. He was in oil and gas. So I lived in India with my mom and my grandma and some of my extended family. Then ages 9 through 14 is when I moved to Saudi Arabia, and we moved with my dad, who had sort of got settled in there at that time. Obviously, that was a huge sort of culture shock going from India to Saudi Arabia, very different sort of culture, religion, philosophies. And for me, the first few days were a struggle because I didn't speak English. I went to an American embassy school. That's where I learned to speak English. And I still remember going back traumatized, telling my mom, I want to go back to India. I don't understand what these people are saying, but it worked out okay. At the time I lived in Saudi Arabia, this sort of in the 80s, there really wasn't a lot of high schools that were predominantly English. So most kids who were my age that time went to other countries for their high school. So I ended up going to a boarding school in Pennsylvania. It was a boys' boarding school at that time. Since then, it has become co-ed. I got a scholarship there, as well as my dad's company paid for quite a bit of it. So it was actually a great opportunity. After high school, I went down to Texas A&M University. I did chemical engineering in my undergrad. I wasn't quite sure if I wanted to go into medicine. My dad was an engineer, so it seemed like the right thing to do. When I just started doing chemical engineering, I realized a lot of it was actually sort of sitting and doing programming, which really wasn't sort of my thing. So that's when I started to realize maybe I need to look at other aspects. And then medicine was something that was always in the back of my mind, so it kind of more clear. Interestingly, around that time, my parents were looking at moving into North America. So they actually ended up moving to Texas, and I've lived there since then. But around the same time, I actually ended up leaving Texas and moved to Queens, where I did my medical school, and stayed in Canada since then. Queens was a great experience. It was a smaller university, so you had tightly knit class. You got a lot of good friends, and it was easy town to get around when you're a student. After that, I did my internal medicine at UBC, which was great. Living in Vancouver, although expensive, it's a fun city to live in. I actually met my wife there. Then after internal medicine, moved to Calgary and did both my cardiology and EP here. At that time, the program directors were Dr. Bilikovich and Dr. Kavanagh, and it was a great experience. Many of my people I trained with that are similar vintage, like Steve Wilton, Andrew Howarth, and Angie Keeley are all still here. So a lot of us have stayed since then. And the trend at that time was in EP. There really wasn't a lot of centers in Canada that did high volume of complex procedures. The trend was all of us would usually go away to the US or Europe to do further training. So I ended up going to Brigham and Women's Hospital, which is one of the Harvard hospitals in Boston. This was a great experience. I mean, it was one of the very sought after centers for training. They did a lot of high volume complex VT ablation, which is the main reason I went. When I was there, I also realized they had a really advanced complex lead extraction program. So I trained in that as well when I was there. And I think it's really good just to be exposed to that system, so you get the benefits and the sort of learn the disadvantages. I mean, certainly it's very competitive. There are like 17 EP centers in Boston, so you're always trying to outdo each other. It was crazy hours too. I remember my wife recalled that I was home 27 hours 1 week total. We also had 2 kids and 2 dogs, so she wasn't super happy with that. But anyway, it's worked out okay. After that, I did look at different places in Canada and actually came back to Calgary, and I'll talk about the reasons later on. But I think I've benefited a lot from having this sort of past, and that's why I sort of focused on it, because I think having exposure to different cultures, religions, languages, customs, and philosophies kind of probably changes how I think and approach things. You kind of have to learn and work, make friends in all those varying environments every few years. I'll speak a little bit about sort of research and QI and other projects I've been involved in. So in my classification, I've what's called a major clinical in our AMHSP system. And usually I've had about 10 to 15% time for research. I've been very lucky to have been in a very academic affinity group, which is the Electrophysiology group. Great mentorship from almost everybody in our group, and also the ability to share resources like being a 10 or 15% researcher, it's hard to have your own research coordinator or nurse, but we sort of share those resources, which is very helpful. Some of my senior colleagues have been very helpful with me, so I've done textbook chapters with them, and also been involved in many local, as a local co-investigator in many studies with industry, as well as sort of government and peer-reviewed funding, and a principal investigator in a few local studies. I'm going to focus on just a few of them just to give you a sample. So I actually had interest in research going back to when I was doing undergraduate in chemical engineering. You're probably wondering why there's a picture of a cow and some ostriches, and I'll sort of get to that. So one of the chemical engineering professors was really interested in looking at methane production from other sources. So he was trying to find anaerobic bacteria. So 2 summers I worked with him, we had to go find anaerobic bacteria either from swamps. But in Texas A&M, they actually had 3 cows that were cannulated. So that's the cannula you can see. So you want to wear a really long glove and reach in there and you can actually pull stuff out of the stomach. It was pretty adventurous because the cows were in a big field. So you had to corral them to one of the sides and do this. And what made it even more challenging was on the other fence was a bunch of emus, and they would try and come and peck at your head while you try this. So, being in chemical engineering and sitting at a computer most of the day, this was like an Indiana Jones adventure to do research. So that kind of made it very fun when I was young. In med school, I really wasn't quite sure what I wanted to do. I worked with one of the orthopods, I think, in shadowing, and he thought, hey, do you want to come research with me for some summers? So I did 2 summers of research, actually published in at the Toronto Wellesley wedge kind of technique for end-stage cancer patient with spinal mets. But since that, especially as being an EP doc, my main area of interest is probably looking at ventricular arrhythmias and sudden death. And I've been involved in various studies over the years. Some of them looking at medications like azimilide, other ones like VANISH 1 and 2, which were Canadian studies, but still multi-center and international, looking at ablation and antiarrhythmics, and VANISH 2 is ongoing right now. Also got to be involved in a special type of catheter that was made with where at the tip of the catheter, a needle would come out, so you could ablate deeper into the myocardium. Involved in that study as well. And the most recent one is the STAR VTM study, which I'll talk about a little bit later, and then also we'll have rounds on it next week. And because of this, I was a secondary panel for the Canadian Cardiovascular Society VT guidelines, and also got to do a review article with Dr. Mitchell and Dr. Sumner in the current problems in cardiology. Being an EP, I think it's hard to avoid having interest in atrial fibrillation. So I've got projects and interest in that as well, and very involved in a lot of the new sort of EP procedure and technology. So the STAR VTM is a stereotactic arrhythmia radioablation. So basically using external beam radiation, like for cancer and tumors, to eradicate arrhythmias from the part of the ventricular scar. We actually got an award from oncology last year for this project. And there's a lot of us involved, but on the picture is Mohammed Faruqi and Nick Plonkwin from Med Physics and Rad Onc. And I'll talk more about this next week, because that's what our grand rounds next week is. I've always had an interest in education, working with trainees. So whenever I can, I try to work with trainees on local projects. Usually, finding things that are interest to both of us. One of the first ones was Arjun Rash. He was an internal medicine. Now he's an allergy specialist. This was really looking at consult letters and what's the best form for a consult letter to send back to the referring. And Bob Sheldon probably mentored me as much as I mentored Arjun Rash on this project. And you'll probably notice when Bob and I write our letters, we do the action items and diagnosis is really based on the results that came out of this. And I've seen other people do this as well, so I feel very proud that it's translating. Then a lot of other projects. So Stefan Wardell's an EP fellow. We looked at when you have a pacemaker and ICD and lead-induced tricuspid regurgitation. And Cindy Belinky was a huge help as a mentor on this paper for me. Then more recently, Bert Vanderberg, who's now in Belgium, an EP fellow here. We looked at high-density mapping catheters versus conventional catheters. And Dr. Quinn and Dr. Wilton also worked with us on this, and they were very helpful to have their input. Also did a QI project with Brennan Ballantyne. He's one of our current EP and heart failure fellows, looking at optimizing medications in our device patients. And ongoing is a project looking at atrial fibrillation with weight management that Chris Pacrul is one of our EP fellows started, and now he's a EP doc in Saskatoon. And there's a variation of the lead-induced tricuspid regurgitation now that we have leadless pacemakers. What are the effects on that? Hannah Yang's a medical student, and Brennan's one of our current fellows. And also Sarah Thai, who's an undergrad in Bachelor of Health Sciences, started to work with me 2 summers ago. And because of COVID, we had to pivot quite a few times as to what she was doing. But most recently, she's done a sort of systematic review, and then also looked at a survey looking at virtual visits. Some of you might have remembered filling it out, looking at both patient as well as healthcare satisfaction, healthcare provider satisfaction. And some of these already been published, and hopefully the others will be soon as well. We were also able to get some sort of grant or equipment support from AHS, UFC, or industry for these projects. much like, being educator, I also try to learn as I go as well. I've sort of attended a lot of sort of leadership, EDI and wellness courses through UFC, HS and CMA workshops. And during COVID, when there wasn't much happening, I actually did an Oxford leadership program that was a few months, which was a great experience and really just learning about leadership and how to be a good leader and different aspects. A lot of the new skills and technology, EP is a very growing field, especially on the technology side. I went to Brigham and Women's to learn VT ablation, including epicardial ablation. So when I was able to come back, I was able to start that program here. And then myself and Dr. Wilton, and later on Dr. Murillo, we've been sort of putting together a left atrial appendage occlusion program, which is, although the volumes are still low, we also have collaboration with our interventional colleagues with Anna Bizios and IS Sachdina. And then the stereotactic radioablation I spoke about, and we'll talk more next week. And then Dr. Exner was probably one of the best device EPs in the world. He's been very involved with subcutaneous ICD procedures and leadless pacemakers, and I've been able to work with him on this, and this has been very helpful. I'm actually currently the proctor for the leadless micro pacemaker in Western Canada. And because of these new skills and technologies, I've been able to work with other centers when they started up these programs, so including Edmonton, Saskatoon, Victoria, and along with Royal Columbian and St. Paul's in Vancouver. So this was a great experience really in teaching your colleagues on how to learn and do new things. Because of some of the new innovative stuff, I actually made one of the top 40 under 40 Calgary's Avenue magazine in 2013, and also the finalist in Immigrant 40 in under 40 in 2013. And later on, I actually got to be a judge for the top 40 under 40 as well. I really owe a lot of thanks to the Libin Institute for this, because I didn't even know this existed. I had, basically somebody from Libin called me in 2013 and say, "Hey, how old are you?" And that's kind of how it got started. So, I think there's a huge value to having the partnership with Libin for a lot of things. I'll speak a little bit about various leadership roles, since that's one of the main aspects of this role. I was EP program director for our EP training program from 2011 to 2018. We usually have about 3 to 5 trainees, and it's a 2-year fellowship, mix of Canadian and international trainees. And it was really a great experience in running a training program with sort of the admission process, various committees, evaluations, and dealing with conflicts, as well as with scheduling. And I think one of the major achievements for me during that time period was we were able to get an area focused competence diploma certification from the Royal College. So it sounds very simple. It was like a 4-year process, and I see Dr. Charbonneau's in the room, so he knows what that's all about. It's a lot of work from PGME and Royal College to get it done. And at that time, we were the 3rd EP program to receive this certification, and I don't know if many others have gotten it since then. This does sort of help us get more competitive candidates for the program. Both Canadian and especially a lot of international trainees really like to have some sort of certification they can take back from the Royal College. So this was, although it was a lot of work, it was very worth it, and I think it's very helpful for our program. I was medical director for our CIED clinic from 2018 to 2021. Roughly around usually about 10 physicians, 20 nurse clinicians, and 2 to 3 medical office assistants as well. This are, as you know, our device implants are mostly done in the OR at Foothills, but we do some in the EP lab, and we have device clinics in all 4 sites. And this was a great experience of working with people within our department, but also outside with anesthesia and surgery and sort of coordinating things and resolving conflicts. Also helped to develop some of the protocols in that time. Not alone, of course, there are others involved, looking at MRIs in patients without MRI conditional devices, anticoagulation protocols for devices, as well as an antibiotic pouch, which it's not cheap. So we had to sort of come up with, what patients would benefit from it and coming up with some criteria. We also started to work on same-day discharge around that time, which worked out well, because then when COVID hit, it was a kind of an easy transition, and we pretty much stuck to the same-day discharges since then for most of our devices. Also started to do some implants in the EP lab in that time frame, which again, during COVID came in very helpful because our ablations were canceled because they're mostly elective and we had very limited OR time. So we actually did a lot of implants in the EP lab for a few weeks during that first wave. I think like many in any leadership position, there were a lot of challenges and things during COVID. I've also been involved in sort of national and international sort of societies. Our Heart Rhythm Societies are our main international society based out of the US. I was in one of the medical education program subcommittees as a lead, looking at the EP's working group, but looking at the clinical side. and was really developing educational content for the website. So involved really sort of meeting with a lot of other EPs across Canada, and we're all trying to get them to basically do some educational content for the websites. Also had various sort of membership committee and other roles in the Canadian Cardiovascular Society also. As many of you know, I was the inaugural Deputy Head of Education and Cardiac Sciences from December 2021 to June 2022. We put the position on hold at that time because I started this interim role after. It was a great experience just with educational programs and PGME. I like to think I helped a little bit with the Royal College Review, although all our program directors were great. So I don't know if I really helped a whole lot, but cardiac surgery, cardiology, and the EPAFC training programs all did extremely well with the Royal College Review. The other one aspect I'm really proud of is, I think it was around 2018, I think it was actually Catherine Cavada who said, hey, we should really look at having some sort of a wellness lead in our cardiology training program. So I started that position, and quickly I kind of realized that when you're looking at trainee wellness, it's kind of hard to ignore physician wellness because that plays such a big role, and started looking into it. And it was one of these things where the timing just worked out well. Jane Lemaire and Richard Lee at that time actually brought in Tate Schonefeld, who's a very, probably the main physician lead for wellness. I think he's now in Stanford, used to be at Mayo. And they had their retreat and I got invited. So we went there and it was a great experience in learning about wellness. And afterwards, I put together a survey that some of you probably remember in the cardiology division had to do and presented to the division. Since then, we started to work with WellDoc, and they put me as a collaborator on their website. And also I got featured as a doc of the week for this in the CMO sort of emails that also work with WellDoc. Really, they weren't initially interested in doing trainee assessments because it was too complicated, but they've sort of since then gotten into that, working with PGME as well. And then, as you know, since July, I've been in the interim zone clinical department head role, and it was a pretty rough time. There was a lot of leadership roles that were kind of vacant when I started. A lot of it was due to the night coverage concerns in cardiology, but also others. And probably one of the best advice I got was from a surgeon from another center. He said, a ship in a storm still needs direction. So although it seemed like a very crazy situation, I was glad that I was able to help. And since then, we've been able to bring some stability to the night coverage, but it's still a work in progress. And it's a work from a lot of other people, not just me, including our previous leaders, including Paul Fedak, Carlos Murillo, and Sandeep Agarwal. And then with our new leadership with Andrew Howard, who's been very instrumental in sort of getting this going. And Andrew Jenkins on the medical affairs side, who's very helpful with a lot of our night coverage. And the realities, especially with our co-management and diversion sort of aspects, AHS leadership, internal medicine, ICU, and many others have been involved. And it's really just a collaboration between many sections. And there's lots of other aspects we have too, where the collaboration has to come up between the different sections. And I think it's really helpful that we have section chiefs. All four are great, very engaged, knowledgeable, and thoughtful. One of the other things I did do in the interim role was in the cardiac sciences, we do have a executive committee and also a council, and they have representatives on the medical physician side, but also on the operations and managers. So both of them range about 20 to 30 people that show up at the meetings. And one of the things I quickly realized, there are a lot of issues that would happen to the foothill side, and we really didn't have a great forum to discuss that because it's hard to have a meaningful, deep discussion on, how much of our time one group should get with that many people. So I've discussed with the section chief as well as Amanda Weiser, executive director, and we formed the Foothills Cardiac Sciences Committee, and this reports to the cardiac executive, but this gives a forum to actually have discussions about local issues that come up in depth. Before I move on to the next section, I thought I should just touch upon my hobbies and interests as part of my background. Most of them involve doing sort of activities like martial arts, working out, or riding motorcycles. There a lot of time I spend with my family. Usually I have 2 kids, 3 dogs, and obviously my wife, and then we also have 2 horses. So that's usually what I do outside of medicine. Looking ahead is always tough. I think it was in the 1880s, the editor of Scientific American wrote that, man will never fly. Then about 10 years later, the Wright brothers had their first flight. I probably hopefully have some insight being in the interim role, and if maybe what are sort of realistic challenges and sort of opportunities we can look at. I've broken it up into sort of different areas. So if you look at the education side, maybe I put it up first because education is always sort of one of my interests. And I think you really need to foster an educational community in cardiac sciences. The deputy head of education role has been put on hold, but probably will need to, search and select that again if I'm in the department head role, and maybe looking at having a cardiac sciences educational committee or something like that to do needs assessments, evaluations, and environmental scans. And also a standardized process. And Libin with Paul Fedak and Christina Faulkner has already been doing this, looking at some of the subspecialties, looking at funding models and providing support. And recognizing educational achievements. And again, having the partnership with Libin is very helpful for a lot of these activities. I think we need to look at and really be on top of balancing the educational activities and clinical service in outpatient and inpatient settings for our trainees. I think as time goes by, this is always going to be something that we'll have to probably move towards. I think, what we used to do 20 years ago is probably not realistic, as we're seeing, and probably what we're doing now might not be realistic 20 years from now. We have to move away from trainee dependent services. The only way to really do that is, if you only have two groups, trainees and staff, you're just shifting between the two. You'd have to have new players enter. That's where NPs and CAs play a huge crucial role, so that, and really engaging with them and keeping them interested and is really important. I think Andrew Howarth has arranged for dinner meetings with myself and him and others with CAs and NPs over the next few weeks. And I think really making sure everybody feels that they're part of the team and are engaged and are supporting each other is super important. I think, as always, mentorship, career planning, and succession planning for trainees, but also junior staff. I think if you're a junior staff in the AMHSP, or if you have research interest, it happens more organically. But I think if you're not, sometimes it's not so organic, and maybe looking at some formal backup plan so that if you don't find a mentor, you have somebody that you can at least sort of talk to. On the research side, a lot of work has been put into what's been developed so far between our clinical department, academic, as well as Libin, including the precision medicine, women's CV health, and then also clinical innovations and preventing and promoting CV health. I don't really think we need to change these directions. I think, these are definitely the way I would support and continue to support. And again, having the partnership between the three is very important to continue. I think EDI is something that any organization should be working on in 2023. I've had some personal experience just from living in different areas. We're worried about implicit bias, but some of the other areas we're lived in were explicit bias and discrimination. I've lived in places where obviously women were not allowed to leave their home alone unless they had a male family companion. One of the places I trained in, they still had KKK rallies in the nearby town that was half an hour away. It was about 25, 30 years ago, but I don't know how much has really changed. Hopefully it's not happening anymore. And also a lot of lessons locally, just being involved in wellness. There's a whole overlap with EDI. And I've been involved with Shannon Riziki and Michelle Keir, and we're all very involved with the EDI projects. And I've sort of been able to help with the two studies that got published. And the reality is this involves, all trainees, patients, staff, industry, everybody that goes through our healthcare system. And we need to, it's easy to say, well, it's everywhere. It's not just in healthcare, but that's not really an excuse. I think we need to always continue to work and engage and try to be better. We have a Libin Cardiac Sciences EDI committee and continuing to engage with them. But on the AHS and UFC side, there's also been more resources and people involved in this, such as Sharon Spicer as the Physician Health Diversity and Wellness, and Jody Plockman, who does the medical staff diversity and wellness role. And as you remember, she actually presented our rounds a few weeks ago. And Kira Makita, who's our sexual violence educator, I've met with all three of them. And I think Kira has some materials that we'll be seeing as well in the next few months. So I think continuing with ongoing education, research, and other activities in this is very important. The one thing that's been reassuring to me, when you're in the interim role, you do get to go to some of the leadership meetings when you're creating cardiovascular society meetings and talking to leaders in some of the other centers. Some of them didn't know what EDI meant or why we would even talk about that. So I think the fact that even if it's not a pleasant conversation, the fact that we're bringing it up and discussing is really important to continue. On the clinical aspects, any academic medical institution, although we have different aspects of research and education and administration, the clinical is key. If we didn't have patients, we really couldn't do all the other aspects. So really having systems where we have patients have access to good care and satisfaction. And of course, tied into that is staff well-being with all medical staff who are taking care of the patient. There are challenges with this across the world, especially after COVID. And I think we're all going to have to work together and use whatever resources we can to make things better. I'll go through some of the specific clinical challenges for each of our sections. So if you look at our cardiac critical care, they also had a lot of issues with the night coverage because they also were very dependent on trainees in the past. So now they have clinical associates and other sort of systems set up. And again, on the staff side, not just physicians in the long run, but also with nursing staff and things in the unit are always an issue. Although it's not directly a clinical aspect, I really like the clinical scholar program that they've started. It's pretty unique. So you can get PICU certification. And the nice thing about it is, especially nowadays with fellowship funding so short, these kind of programs are great because you self-fund by doing clinical work. And this sort of provides a way to learn where, there isn't a requirement for fellowship funding. And then just in CVICU in general, there's increased patient acuity and as well as longer stays for some of the more complex procedures with aortic interventions, ECMO and VAD, which all we need to sort of figure out how do we accommodate that. Cardiac anesthesia side, there's more and more minimally invasive procedures coming, new procedures that require TE and other aspects. How do we work with anesthesia? I always think when you do procedures, anesthesia is kind of the glue that holds us all together. So really important for us to build programs with them and make sure they're getting all the training that's needed for these new procedures that are coming. A concerning feature is that there is a huge shortage across the province for anesthesiologists. And I think we do have to worry that, our cardiac anesthesists could get pulled away for other things and really sort of, trying to figure out how we can work with that. On the cardiac surgery side, again, funding, which is always a common issue across many aspects of healthcare, especially for the newer procedures like aortic procedures and minimally invasive CABG procedures, and also with staffing of the surgical units for post-op care. And again, like all sections, I think, the fact that we're a department is so we all work together, and collaborating and working together is going to be very. On the cardiology side, I think we've already mentioned the clinical coverage, especially with CAs, NPs, and extenders is very important. And AHS has really been supportive as well. I don't know if many of you know this. I think last spring, our CA number was around like 5 or 6, and now we're up to, I think, 11, and this is going to continue to increase. And the idea is that hopefully we'll have enough support for both day and nighttime coverage at all sites for all services. And also on a bigger picture, making sure there is equitable distribution of services and coverage. I know Andrew Howard's been working a lot on this. I think another big topic that we sort of need to face on the cardiology side is, how do we add value to hospital work? Cardiology is one of those unique areas where you can actually do a lot of community work with imaging, with clinics. And Andrew Howard and I have been talking about this quite a bit, is also with AHS leaders and UFC leaders to figure out how do we, add value to doing hospital work. Many of us know hospital work is probably the hardest part. You have sick patients, long hours, completely unplanned things that happen. And how do we make that something that's valued by our colleagues? I do think that the AMHSP is a great program, but the recruitment and retention are a concern. If you look at our numbers about 10 years ago, it was probably close to 30. Now we're probably close to 20. I think we sort of have to look at how do we recruit people who have interest in academia and research, and how do we retain them? I guess the summary in all sections is really, similar to many healthcare systems. We have limited resources for funding equipment, staff and coverage. But I think we have to keep working on how do we make things better. When I started in this role and recently, I realized that especially on the cardiology side, the procedures that are done, such as ablations, TAVIs, CATs, devices, don't actually appear on the ACATs. The ACATs is in Alberta, a system that keeps track of people waiting for procedures. And so we're actually having meetings to figure out, what to do about this, which is really frustrating for our patients. Patients has waited 1.5 years for an ablation, seeing all this stuff in the media about how we're doing things to increase procedure volume, decrease times. And when they realize that the procedure they're getting is not even on the radar, it's very disappointing. There may be some opportunities for space. As you know, there's a new cancer center building. So the old one might have some opportunities for clinics or other sort of spaces, maybe some imaging. we've also discussed having a procedure room, probably in unit 104, if possible, that maybe access to C-arm fluoro, where you could do maybe some cardiac biopsies, right heart caths, which could offload some of the cath EP labs and echo lab for minor procedures, which again, I think we have to be sort of creative and make use of the space and things we have to make the best of our patient care access and satisfaction. And I think for all sections, burnout, wellness, and EDI are things we'll need to continue to work on. I think using our local sort of committees, as well as engaging sort of the UFC and HS resources as well. Again, these are always going to be a work in progress. I don't think there'll ever be a time we're going to stop and say, oh, I think we're done with all this now. So I think we have to keep that in mind, and really just engaging and collaborating is going to. I saved this slide till the end because this is sort of, why did I move after Boston to here? I looked at Toronto and Vancouver as well, and some other sites. And I think the same reasons are still relevant for why I'm applying for this position. A lot of us, get frustrated by our medical system at times, but realistically, when you look at across the world, I think the Canadian medical system is still a great system. When I was in the US, you had great care, but there was 50 million Americans who didn't have access to any care. That's more than all of Canada. And especially locally for me, one of the main attractions was the fact that you had cardiac surgery, cardiology, cardiac anesthesia, and cardiac CVICU all under one department instead of being spread out across different departments, which is the traditional kind of setting. Because I think these groups really need to collaborate together on a lot of things, and going forward is going to be very important. And the fact that we're one department is very, very helpful. And Calgary actually presents a great opportunity for clinical research and educational opportunities. In many centers, the fee-for-service docs are at a different hospital. The academics are at one, which I don't think is a great setting. I think the mingling is important, and being able to share ideas and work together. And the other main reason really why I like Calgary was I think our colleagues in general are very collaborative, supportive. With the department institute, that's also very supportive. And one of the issues, which is nothing we've done directly, but Calgary is still a great place to live in. We frequently make the top 10 cities of the world. And affordable housing is really important. When I talk to leaders in Vancouver and Toronto, this is something they struggle with, where they can't hire people. One of the cardiology leads at one of the smaller hospitals in Toronto said they haven't hired a cardiologist in the last 7 years, which is worrisome. And when I talk to some allied health groups in Vancouver, they said some of the EMS workers, they basically buy an apartment together. So when they're on shift, they can come and share the apartment because they can't afford to live anywhere. So I think we're not responsible, but we could make it's an advantage we need to make use of, and that can help with recruitment and retention. And at least in the interim role, I've really gotten a sense that there's a lot of support from AHS and UFC and Libin for a lot of the things we do. And the obvious example would be on the cardiology side with the CA recruitments, where we've been more than doubled, as well as working with other departments on working with diversion and co-management, with GIM and ICU at South Health Campus. And recently, we now have planned meetings to look at Rocky View and PLC as well for those kind of management plans when it comes up. Because the reality is, it's never going to be perfect, and things will happen. I thought I would put this quote in there. As you know, in the last few years, we've had some of our cardiology, on the cardiology side, some of our colleagues leave to other provinces. When I ran into one of them recently, his first comment was, "You don't know how lucky you have it in Alberta." So I think it's a really good thing to kind of keep that in mind. And I thought I should put a slide at why me at the end. So I think for me, the interim role provided a great experience, and it was really, although it was on the clinical side, I think I would find it a good experience for the department role, both the clinical and I think my background and experience sort of bring some strengths to collaborating with different people and groups, and this will be really an important part of this kind of role. My mission really would be to have a very inclusive, productive, and safe environment for all learners and staff in cardiac sciences, and the vision of Calgary being undeniably the best cardiac center in all of Canada. Questions or comments? Oh, sure. Yeah. Oh, yeah, there's something in the chat here. Oh, Greg said, "Now I know why you're such a good cowboy." Sure. No, there were no other questions.
commenting anything.
Yes, I know what Greg's referring to. My daughter does a lot of Western riding, so often I'll send him pictures when I'm like sweeping out the arena or something and saying, wow, you know, after 18 years of post-high school training, this is what I'm doing.
Put your hand in a cow's stomach because you can rig a riding arena.
Yeah. Yeah, good point. I think in general, when we look at, recruitment that we're doing that's been happening, we're still doing okay compared to a lot of other centers. There's a lot of people interested. We're probably still, turning down some people as opposed to recruiting everyone who applies. Yeah, the concerns of the local cardiology, it's a very good question. So I've talked to other people in other centers about this. And I've actually had different opinions from, men and women that I've talked to. Yeah, all the men sort of say, oh my God, I can't believe you had all this stuff come out, especially with the EDI issues and things like that. A lot of, women cardiology colleagues, they've kind of said, no, a lot of this stuff happens everywhere, but it never gets reported. We can't even talk about it. And this is from pretty prominent centers in Ontario and Quebec. So they actually view it as, it's a positive that you're actually discussing this, you're allowing people to publish on this. And I think as many of you know, there's, other similar articles coming out about a lot of the centers, there's lots in the media. So I actually think we're a step ahead that we're actually facing this and not, pretending it doesn't exist. I do have concerns about the AMHSP recruitment. Andrew and I have talked about this several times. And basically, part of it is, cardiology is a very lucrative field. So there's always, I think it always is going to be much more appealing when you look at the financial side to go fee for service, as opposed to coming into an AMHSP. And especially when you look at the AMHSP, sort of the Invictus report, what cardiologists are making is a lot less proportionally compared to some of the other areas. And this is something we're going to have to sort of face. Otherwise, it is really going to be hard to recruit, especially academic candidates. Does that answer what you're asking, Sarah, or did you have more to it? I forgot. Okay. Okay. Yeah, it's a good question. So I think on the recruitment side so far, it hasn't been a big issue. There's lots of people who've been interested. But on the AMHSP side, I know Andrew and I have been talking about who do we talk to, how do we get things going to change that. And obviously that's going to be a big process and not a quick fix. Yeah. Yes, yes, that's true. Yes. Yeah. Oh, sorry. Yeah.
Also from
Yes.
Raj made a great talk. So the
Thank
most
you.
challenging part.
Yeah, I think, being in the interim role, I sort of got a bit of a flavor for it. And I think there's probably two aspects. One is time management for sure, because there's a lot of meetings, a lot of work you have to do that's sort of behind the scenes and, making time for all that. The second is, as Raj probably knows for sure, there's a lot of conflicts that come up when you have, I think we have about 100 physicians and then probably another 50, including trainees and PCAs and over 1,000 allied health. And those are always tough to deal with. There's not an easy answer. I mean, my attitude always has been to, kind of face it and, see where it goes, have honest, open discussions. I think that's probably the only way to really kind of go forward. And also keeping in mind that if you come in with a preconceived notion, maybe, realize that so you're not pushing your own agenda. Yeah, thanks, Lori. I mean, we could spend a lot of time talking about this, but I think some of it, I think you probably already know, you, Lori, would know, but others might not, is, as you know, with Rocky View and PLC are sort of expanding some of their spaces. So we are looking at actually expanding the size of the CCUs in both those places. And as Lori probably knows, you know, South Health Campus is probably where we really hope to expand in the long run. I know that's not going to be maybe in the next few years, and, you know, it could be longer, but really that's where the infrastructure is. That's where the south of the city is really expanding. The hope when South Health Campus was first built was that we would replicate Foothills there with cath labs and cardiac surgery. And obviously that hasn't happened, but, you know, that really is the hope. As all of you know, cardiac problems are a problem commonly as people age. And with, you know, the Calgary population growing and aging, you know, that is a big issue. In terms of surrounding zone areas, I've also in the committee that looks at the South Zone sort of cardiology realm, and I know they've got a proposal to open cath labs and things in Lethbridge. Again, when you have detailed and when you look at the numbers, it's, you know, it's always unclear because about 400 of our caths come from the South Zone. But if you do those 400 in Lethbridge and you hire 4 interventionalists, that's only 100 each. And are they going to do 1 in 4 call to do 100 caths a year? You know, those are the sort of challenges we face. So I think, you know, there are some clear expansion plans already in process, but I think others will have to happen. But I think it's always a, you know, idea of managing the expectations, what we can accomplish. Like Red Deer has plans to expand, as everyone knows, they've got funding, but, you know, they're doing cardiology diversion because they don't have enough cardiologists, right? So those are all sort of the concerns and challenges we'll have to face. Thank you. Thanks, Mark. No, absolutely right, Lisa. And just to put some numbers behind that, I think, you know, pre-COVID, so, you know, this data is published, right? Not just from locally from Veldoc, but our own surveys. But if you look at sort of Medscape and stuff, you know, amongst cardiology in general, the burnout is usually around 30 to 40%, but after COVID, it's actually around 50%. I mean, that's very concerning. And there's not a general population burnout, but I'm guessing from looking at stuff, it's around 20%. So we're all always double. Tied onto that is, of course, you know, things like depression and suicide that sort of come out with those areas. So in terms of, you know, what is the best way to address that? I sort of think of it as, you know, if you have a friendship or relationship that isn't going well, I think the only way really is to engage with being open and transparent, and having honest discussions. And although that's uncomfortable, I know Andrew Howard and I talked about this, you know, how do we do that on the cardiology side? That's really the only way to move forward. I think, you know, a lot of times maybe people in leadership positions have some ideas, but maybe you don't, right? And unless you can have open discussion with all the members and they feel honest. So I think the first step is really creating an environment where people feel they can be honest and have discussions. I think we have an added challenge in cardiology that other groups don't, which is that we don't have to work in hospital. We can actually work outside, right? Which is the other aspect that we need to sort of figure out how do we work with that as well. Yeah, really good question, Steve. I mean, as you can imagine, you know, Paul and I have had lots of, you know, discussions on that. And you could say, with me, Paul, and the section chiefs and, everybody else, we all work well together. And it's the format that other institutes have had. So I don't think there should be any big concerns going forward. But you could say, well, if I'm not the department, somebody else gets it, or down the line, and Paul is no longer in that position, will that cause tension? I don't know. It's hard to know. I think where we are right now, it doesn't seem like it would, because we're so integrated. We're, do a lot of things together. As you may or may not know, Libin is actually comes to our executive meetings, our council meetings, or I go to their board meetings in the interim role. So I feel like we're quite integrated. So I don't think it's an issue, but will that always be an issue if the people change? That's hard to know, I would say. There's coffee and treats in the back too, for those in person. Okay, well, thank you everyone for coming and taking time this morning.